हाँ हाँ मैडम, वेलकम मैडम, वेलकम वेलकम। हेलो,
audible?
hello, yes yes ma'am, you are audible. Yeah,
Okay.
audible.
Okay.
Yeah.
Good afternoon, everyone. I, Dr. Pooja Sahu, welcome you all on behalf of Shalakya Tantra Department, AYURVED Mahavidyalaya, SION, Mumbai. Our institute is granted aid by Government of Maharashtra. Our topic for today's webinar is Ayurvedic Management of ENT Disorders. Now, I request our HOD and Vice Principal, Dr. Ravidas More sir, for the welcome speech.
Good afternoon to one and all. I would like to welcome our guest speaker, Dr. Sunita Magar Madam, who is a professor in the Department of Shalakya Tantra, YMT Ayurvedic Medical College, Navi Mumbai, Kargar, Navi Mumbai. I have immense pleasure to welcome Dr. Atul Bhardwaj sir, who is Assistant Professor, Charak Brahma Prakash Medical College, Kheda Dabar, New Delhi.
Thank you.
I would also like to welcome today's chairperson, Dr. Sarla Dudat Madam, who is Associate Professor in Shalakya Department, Kodar Government Ayurved College, Worli, Mumbai. And the next chairperson for second session, Professor Dr. Deepak Sawant sir, Professor in the Department of Shalakya Tantra, Government Ayurved College, Usmanabad. Department of Shalakya Tantra has organized today's webinar to emphasize and establish the important aspect of the ENT management of ENT disorders. As we all are aware of this fact that there are many solutions for the complicated diseases as well as new diseases in the Ayurvedic therapy, so that we have to explore and reflect more light on this thing. This webinar will boost the confidence among the participants to implement the simple procedures, Ayurvedic procedures, therapeutic measured in the management of ENT disorders. Their day-to-day practice. I ensure this webinar will enrich your knowledge. A big thanks to each and everyone present here and who have joined this webinar. Thank you. Over to Pooja.
Thank you, sir. Now, I request Dr. Chandana, PhD scholar, Assistant Professor of Sri Dharmashala Manjunatheshwar Institute of Ayurveda and Hospital, Bangalore, to kindly introduce a speaker for our first session, Dr. Atul Bhardwaj, sir. Dr. Chandana.
Recording in progress.
Kindly excuse us for the technical abnormality. I request Dr. Chandana to kindly introduce our guest speaker, Dr. Atul Bharadwaj. I regret the technical disturbance. I introduce our guest speaker for the first session, Dr. Atul Bharadwaj sir. Sir is Assistant Professor in Department of Shalakya Tantra, Brahma Prakash Ayurved Charak Samsthan, Khera Dabar, Delhi. Sir has completed his BA/MS from Delhi University and his MS from HP University. Sir has a total teaching experience of 15 years in Shalakya Tantra as assistant and associate professor in different institutions. Sir has many research-oriented high points and contributions. Sir has done many research in application of Anulom Vilom Pranayam in nasomucillary action and validating the result with gold standard estimation procedure, that is Anderson's saccharin test. Sir has specialization in the field of ENT surgical procedures and ENT emergencies, including pain management. Sir has explored sharing area between Ayurveda and modern counterpart in the field of ear, nose, and throat disorders, particularly establishing and justifying classical treatment of various ENT disorders with modern parameters. Sir has published curriculum book of Shalakya Tantra ISBN. International published 8 original full research papers. Sir has published many national papers in the Journal of Ayurveda, Department of Ayush, Government of India. Sir has many national and international journals published. Sir has around total 6 paper presentations about introduction of Ayurveda to medical students of St. Catherine University, US. Sir has been awarded the best presentation in Academic Staff College, BPSMB, Kanpur, Kalan. Sir has been a part of panel of editorial board for Journal of Environment and Life Sciences. Now, I introduce our chairperson for the first session, Dr. Sarla Dudat Madam. Ma'am is Associate Professor of Shalakya Tantra Department, Poddar Government College, Mumbai, Worli. She has a total teaching experience in the field of Shalakya Tantra of more than 28 years. She has a keen interest in research field. She has presented about 12 international papers in various conferences. She has presented around 20 national papers in various conferences. She has chaired many government committees. I welcome you, ma'am. Now, I request Dr. Atul Bharadwaj sir to kindly start with his session.
Thank you very much. Am I audible? Am I audible, ma'am?
Yes, sir.
Thank you very much for the introduction. I'd like to acknowledge Ravi sir, the moderators and principal sir, also the coordinator of this event also for inviting me and giving the opportunity. To be honest, from past 7 to 8 years, I am much into a surgical practice. And primarily, I have started from endoscopic nasal surgeries. Most of the days, out of 10 surgeries, except for these COVID times, 8 surgeries are used to be our mid-ear surgeries. So nowadays, I have focused more on, you can say, on mid-ear surgery, total reconstruction, etc. But I've always been a keen student of rhinology, especially after 2012, when I bought my first endoscope. I would able to clearly look what's going on with different pathologies, like what is the nasal health in sinusitis, what is polyp is, what kind of a surgery you can offer to the patient. Apart from that, I have got uh, uh, keen interest in the field that how different type of nasal drops, like oil-based nasal drops or aqueous-based nasal drop or sprays or powder-based drop, powder-based nasal drugs happens to be a different kind of a distribution pattern in the nasal cavity. So even we have, you can say, colored many nasal drop in order to study how the different type of nasal drop tends to diffuse in what kind of areas in the frontal sinus cribriform plate phase of the sphenoid rostrum do they actually penetrate into the sinuses. So today's topic is related to that topic, you can say my commencement from this topic will be, I will share the screen with you.
Hello.
Hello. Hi, sir.
Share your screen.
Okay, I shared, sir.
Okay, it is visible, sir.
Are you visible now, sir? Okay,
Yes.
let me take a pen, sir, first. Okay. I will enlarge the picture, then I will take a pen, then we can start.
Yes, sir.
Okay, pointer option and a pen. Let me shift this to this side now. And to this side. So today's topic will be clinical application of the nasal drug delivery system, which is called as Nasikaram. Any drug which is given through the nasal cavity is supposed to be the Nasya. So before jumping into the topic proper, let us have a quick look at the very, very important phenomena, which is called as mucociliary clearance mechanism. Mucociliary clearance mechanism is the nasal cavity is lined by a epithelium, which is respiratory epithelium, and on top of it will be the cells, and different cells has got, one cell is about 100 to 200 cilia, and these cilia continuously beat from anterior to posterior, from anterior nasal aperture to choana, in order to shift the entrapped particles and different kind of secretions. So if the nasal cavity is in good health, then the ciliary beating is the single most important thing. And you can say, like the bacterial is entrapped there, the nasal cilia will beat through these two phases, gel phase and solution phase, and constantly the entrapped particle or the foreign particles and the secretion will be pushed from anterior to posterior. Throughout life it is done. So it is directly related to the health of the mucociliary clearance mechanism. MCCM is directly related to the expression of the disorders. So I am going to name two very, very important names. One is the, you can say, father of modern rhinology, that is Stamberger, is from Austria, and he has said that mucociliary clearance mechanism is the single most important factor in inflammatory disorder of the paranasal sinus. I have done some study also, or a published paper also on this. So in case of a rhinosinusitis, even in allergic allergic rhinitis, and even smokers, they have got a different time from anterior to posterior shifting. If you mark the nasal cavity with saccharine in the anterior nasal part of the case cavity, the time taken from installation of the saccharine or the sweet taste till it is appreciated by the patient is called as mucociliary clearance time. So in case of disorders like sinusitis or smoker patients, this time increases, directly reflects that measurement of this mucociliary clearance time is directly related to the health of the nasal cavity. So Kennedy, which again the famous Kennedy, has also approved the fact that it is single important factor. This beating of the cilia is the single important factor in the genesis of the nasal cavity disorder, particularly rhinitis and rhinosinusitis. So measurement of this mucociliary function will directly leads to you some kind of assessment of the nasal cavity in its disorder, particularly is talking about rhinosinusitis. So for the audience sake, for the beginner's sake, this is the lateral nasal cavity. This is the cavity. This is the part of the cavity we deals with so much of the surgical implication, as well as all of the polypoidal arch generated in the middle meatus. This is middle meatus, then inferior meatus. This will be the superior turbinate, superior meatus. This will be the sphenoethmoidal recess. This will be the face of the sphenoid, and inside it will be the sphenoid sinus. This is roof of the sphenoid sinus, which is called as sella. It is called as sella. And this is tuberculum sella. This is dorsum sella. This impression is nothing but the internal carotid artery, ICA, and the optic nerve crosses the lateral wall of the sphenoid sinuses, and the groove is called an opticocarotid recess. This will be the clivus. So this is the opening of the eustachian tube. So when we talk about absorption of different nasal drops or nusset through the nasal cavity, we are talking about two prepositions. First is absorption of nasal drops or drugs through this area. This is nothing but the respiratory epithelium, which is pseudostratified ciliated columnar epithelium, and this accounts for 90% of the mucosa of the nasal cavity. This respiratory epithelium, which starts from the nasal cavity, goes into the nasopharynx, the eustachian orifice, up to the middle ear, then goes up even up to the alveoli, is lined by pseudostratified ciliated columnar epithelium, which is also called a respiratory epithelium. So 90% of the absorption we are talking about, 90% surface area of the nasal cavity. The surface area is about 180 centimeters square. And the volume of the nasal cavity is 15 to 19 ml. It can take 15 to 19 ml. But this is this area. This is called as cribriform plate. This is the frontal sinus, you can say. This is nasofrontal recess, which opens into the middle meatus. Underneath this middle turbinate, you will see all this. And this is the anterior part of the cribriform plate, and this is the posterior part of the cribriform plate. Just after this ending of this frontal opening, this is a commencement of the cribriform plate. Cribriform plate is a part of ethmoid bone. The posterior part of the cribriform plate is also part of ethmoid bone. The flat part, just this roof of the sphenoid sinus, is called as plenum sphenoidale. So plenum sphenoidale, this is sella turcica, and then dorsum sella. From anterior to posterior, it will be frontal sinus opening, the anterior cribriform plate, posterior cribriform plate, and then the plenum sphenoidale, then the sella, and then will be tuberculum sella. So let me take you to the dry skull specimen. This is the cribriform plate. So this is the cribriform plate, which has got numerous, about 20 to 25 opening for the you can say innervation of the olfactory neurons into the nasal cavity from anterior cranial fossa. This is anterior cranial fossa up to the frontal anteriorly, and posterior part will be the lesser wing of the sphenoid. And from lesser wing of the sphenoid to the tip of the petrous part will be the middle cranial fossa. This is anterior cranial fossa, this is middle cranial fossa, this will be the foramen magnum. So this area directly transmits the olfactory nerve, olfactory optic oculomotor. These are the first three. The first cranial nerve, the olfactory nerve, is directly extends from the olfactory bulb. Olfactory bulb is here. From olfactory bulb, it transmits through the various openings into the cribriform plate. Is a part of ethmoid bone, and we have got two part of the cribriform. First is the cribriform plate, this medial part. The second one is the lateral cribriform plate, and it is topped by, on top of it will be the frontal bone. So these ethmoidal cells, we do look at this. If you can see this, this is opening of the cribriform plate by different you can say opening of the various olfactory neurons, entry into the nasal cavity. And look at this. This is the ethmoid bone, which is hollow from top, and it is covered by the frontal bone from above. and the part of the frontal bone which covers from, which tops it, is called as fovea ethmoidalis. Fovea means impression. So the impression of the frontal bone on the ethmoid is called as fovea ethmoidalis. So let me again take you to, so this is the area and this is the entrance of the nasal cavity. So you can say this is the part of the nasal cavity which has got the olfactory fossa, and the fossa is also called as olfactory fossa. So olfactory fossa, cribriform plate, fovea ethmoidalis are different things. So when we talk about, so this is also a difficult, seems to be an endoscopic picture, but let me make a easy representation of this. This is the orbital plate between the orbital cavity and the nasal cavity. The septum has been removed. All of the cells have been removed. So this is the opening of the frontal sinus. This is anterior ethmoidal artery, and this will be the remnant of the septum, and these are the remnant of the middle turbinate. So in between the middle turbinate and the remnant of the septum, we have got cribriform plate. So we are looking through the nasal cavity. We are having an endoscopic looking look of the nasal cavity, of the roof of the nasal cavity, which is called a skull base. What is a skull base? So skull base, from anterior to posterior will be the frontal, then the cribriform, then the planum, the planum, then the sphenoid proper. This is called as skull base, the surgery of the skull base. So this is anterior skull base, this will be the posterior skull base. So the olfactory neurons enter from this part into the nasal cavity and supply the superior part of the superior turbinate and some part of the septum, which is responsible for the absorption of different nasal drugs which are delivered through the nasal cavity. So we have got distinctly, let me shift this. Sorry. Okay, so already we have talked about this. We have the nasal cavity is lined by two type of epithelium, in fact 3 type of epithelium. One is squamous epithelium, 90% of it is a respiratory epithelium, and the drugs which are absorbed, the nasal drops or oil we use through the respiratory epithelium are drained directly into the systemic circulation. By bypassing this blood-brain barrier, it is directly drained by the blood-brain barrier. But there are various limitations also of this absorption. This happens to be the larger area of the nasal cavity which is lined, but the area which is responsible for absorption of a lipophilic, we are talking about nasikaram diffusion into the brain, then this part is important, not this respiratory part. This part is not responsible for quick absorption into the CSF through the olfactory neurons, but this part is responsible through the olfactory cleft or olfactory fossa or cribriform plate or anterior skull base, whatever you can say. So we have got 2 distinct type of absorption mechanism. One is through the respiratory epithelium, through which you can see the mucosa, the epistaxis epithelium, and the second one is yellowish, thickish mucosa, which is yellowish because of the presence of lipofuscin and responsible for absorption of, particularly the absorption of lipophilic drugs and directly delivering into the CSF. So this is again, so it seems to be quite, you can say, quite simple that drugs which are introduced into the nasal cavity in the olfactory fossa happens to be diffused into the CSF. But this question is not so easy. About you can see this is the cribriform plate, and these are the bipolar olfactory neurons into the terminating onto the mucosa. So either the drug may enter into the neuron itself, olfactory neuron itself, in its exoplasm, and will diffuse into the you can say olfactory bulb, then into a different part of the bulb. This is called as interneuronal, transneuronal, through the neuron, through the olfactory neuron. 15 minutes. And the second important, which is very, very important, is these olfactory neurons have got a perineural epithelium. Perineural epithelium, there is a potential space between the olfactory epithelium and the cribriform plate, and this space directly is connected to the CSF, because the olfactory fossa, or the superior part of the ethmoid bone, has got absolutely dura attached to it. And between the dura and the subarachnoid space is the CSF. So it seems to be that CSF is far from the olfactory plate, but it is absolutely close to it. And the drugs through this perineural in the sense is from the sides of the neuron, they directly gain entry into the CSF space. As you are well aware of the fact that the meninges, the dura, arachnoid, and pia, continues onto the optic nerve and various cranial nerve as well. So the cranial nerve has got a continuation of the dura, arachnoid, pia. So it seems to be distant, but it is very, very close to it. And the drugs are successfully drained, depending upon various factors, are successfully drained into the CSF space, then into that it is disseminated in different part of the brain. So we have got two types of spread of the nasal drugs. First is through the neuron, which is slow. It will take from days to even months to distribute or disseminate or segregate. The drug which is entered into the neuron will take some time. But if the drug happens to be gain entrance in this perineural space, then it is quickly assimilated, distributed, drained, you can say, into the CSF, and within span of few seconds to few minutes, it is made available to different part of the brain. So this is not a hypothetical kind of a situation. We have got numerous research papers, about 70 of them, studying how come those two type of delivery system are different from one another. So this is through the neuron. This is the perineural, which is quick, and the second one is through the neuron into the olfactory bulb, you can say. Then it disseminates into the thalamus, subthalamus area, and the corpus callosum. But it will take some time because the movement of the exoplasm is slow. But CSF is constantly circulated throughout the is circulated in the meninges continuously. It is secreted continuously. It is absorbed continuously. So CSF is in continuous motion, and the time taken of the CSF delivery will be far less than of the neuronal spread. So I already I think have explained this. So through the neuron and along the neuron, you can say. So transneuronal and perineuronal spread. So this is again the same. Interneuronal you can call is through the neuron, or extraneural along the neuron, through the perineural space into the CSF. Look, this is a CSF space. This is olfactory bulb, and olfactory bulb is covered by the dura, and along with that comes the pia, and in the comes the arachnoid, and in the subarachnoid space we have got CSF. So look at this. This is absolutely has got proximity to the olfactory bipolar neurons, which is exposed to the environment, external environment, and hence can be easily accessed by the nasal drugs, various type of nasal drug delivery system. So we have got two type of transport, you can say also. So we have got paracellular transport and paracellular is like a cell along the cell, transcellular within the cell. So this is quick, and I am talking about through the respiratory epithelium. We have got paracellular, which is aqueous base. So this transcellular, which is only open for oil-based medicine or lipoidal drugs, lipophilic drugs, you can say, lipophilic drugs. So in short, I can say that almost all of the studies say that lipophilic drugs are transcellular, you can say, all of the lipophilic drugs are absorbed through the transcellular, through the cell, and all the aqueous drugs are absorbed through the paracellular. So this is very, very quick, this one, and this one is slow. So advantage of the nasal drug delivery system, you are well aware of. It's a non-invasive route. You can compare this nasal drug delivery system or Nasyakaram not with the oral medication. You can compare only it with IV route or parenteral route, you can say. So if you going to compare the drug distribution by oral route, so that is not appropriate. You have to compare the drug delivery, the bioavailability into the various tissues. It is comparable to the parenteral route or IV route. So it is quick, very quick in action because the direct delivery into the CNS, it is a rapid drug and it bypasses the hepatic metabolism as well. So in the oral drugs, it consumed, it goes to the stomach, then it goes, it is absorbed through the wall of the gut into the portal vein, and the portal vein passes through the liver, and then it is drained into the systemic circulation. But in case of a nasal absorption of the drugs, this kind of a metabolism pathway is bypassed or circumvented, you can say, or avoided, you can say, and directly the accessibility is to the systemic circulation. It has got a better bioavailability. Even some drug has 100% bioavailability. If you're talking about certain vaccines, lipoidal drugs, and various opioid medicine, they have got about 100% of bioavailability compared to the parenteral route or IV route. And what are the limitations? The limitation is the surface area is not as large as of the Vasti, you can say. So Vasti has given a full treatment. It is compared to the as a complete Purna Chikitsa mana usko. But the nasal cavity, because we have got a limited area, a mucosa, area in the sense of mucosa, because mucosa is directly related to extensive blood supply, and the drugs may be drained directly into the systemic circulation, which in case of a Vasti is a large area, but nasal cavity is limited by and when it can be administered, it cannot be removed. Also, there may be a irreversible damage to the nasal mucosa. Various factors which are responsible for distribution. What is distribution? So distribution is supposed to be the nasal cavity, and you are giving a drug or nasal spray, or you can say oil-based medicine. So how it will disseminate into the different part of the nasal cavity will be the distribution. Absorption is totally different thing. Absorption is bioavailability of the drug is called as absorption. So these type of concentration, what is the concentration of the drug? pH has to be between 4.5 to 5.5. This is the pH of the nasal cavity. It has to conform with the nasal cavity pH in order to absorb the nasal cavity. Size of the drug, very, very important. And size of the particle is measured in Daltons. So any size of medicine, micelle or vesicle greater than 1000 Dalton DA will not be absorbed, because the channel will not open. So we can do a lot of things for opening the channel to make the drug more absorbable, distributable, and so the size of the particle is absolutely important. So in the modern research of the nasal cavity drug delivery system, they have developed numerous means by modification of the drug carrying a precursor, or changing the physical property of the drug, changing the particulate size of the drug. They have even delivered as large as 31,000 Dalton particle into the CSF through the nasal cavity. So these are various modifying factors which can change the bioavailability, absorption of the drug. So it is also the mucosal contact time. Like I will give an example, like the mucosal contact time of a oil will be more than of a aqueous based drug or decoction, a cloth drug, because if you introduce some kind of a oil based medicine, it will stick to the respiratory mucosa or auditory mucosa and will retain at the same place for some time, you can say. But in case of aqueous based medicine, cloth based medicine, decoction based medicine, this is not going to happen. They will be quickly washed by the mucociliary clearance mechanism, and the time taken of the time available for the drug to make its entry or do its action is relatively less. So let we take, for example, different type of nuts we use in common practice. Like I am taking Anutel nuts, which is oil based medicine. Shadbindu Ghat is again a oil based or a lipid based drug, you can say. This is not oil based. Oil based medicine. This is a lipid lipoidal drug or lipophilic drug, you can say. Katfalchurn is a dry powder, and Aupid, Pipilia Aupid nuts, we will take it as a decoction base, so it's a aqueous base, you can say, drug. So we will take different type of. So in case of a probable mode of action of the lipid based drug is lipid based drug like Anutel and Shadbit, like they are better absorbed, through the periciliary layer, it drained into the CSF, into the systemic circulation, and the contact is the time available for the drug to actually enters into the systemic circulation is more in case of oil-based medicine. What are the disadvantages? The major disadvantage is because in case of a oil drug in a congested cavity, acutely congested cavity or arm avastha, you can say, because it is then subsequently reduce the movement of the ciliary transport or mucociliary clearance mechanism, which itself can be faster in case of acute disorder. Like the patient is having acute rhinosinusitis and the cilia are already congested, having 3 times more secretions than the nasal cavity, and then you are adding a heavy oil-based medicine, and it will substantially lower down the ciliary breathing mechanism and perhaps will give to also some kind of complication also, and hence are denied in or not recommended in acute phase of the disorder, which is called as amavasa in our literature. So this is the reference again. Navam pratishyaya apasya sarvam shaya pana. नव प्रतिशय के अतिरिक्त सभी प्रतिशयों में अगर जो है ये आम अवस्था इज चेंज्ड इनटू अ पक्व अवस्था काल बन जाने पर, तो तब भी then only you can, even if you want to start a nasal drug delivery, then you should start with a aupidinus or aqueous based medicine. So amavastha is not routinely, you cannot use nasyakarm in case of amavastha, which is a very important and even justifiable point in through the modern literature also, and we have got a consensus on the different type of Ayurvedic literature also, that in case of amavastha, the nasal drops should not be used, and even if the pratishaya matures into a pakva pratishaya, you should start with the aqueous based drug, not from the oil or a lipoid or a lipophilic drugs. So let me take you the literature again. Every type of pratishaya, not this jeed pratishaya or every type of pratishaya, follow arm and prapakva, and you have to be absolutely versed with the features of the arm pratishaya, and they are clearly also delineated in the literature. So nasal discharge clearly is a feature of arm pratishay. So nasal cavity is already discharging. There is a rhinorrhea. Forget about. Hello, am I audible, sir? Hello, hello,
Yes, sir,
Yes,
you're
sir.
audible.
hello. Okay. It was a minor, you can say, a technical glitch, you can say. So aruchi is the most important, that is anorexia. But nasa srav is again very important. So I have seen in many also. So rhinorrhea as such is not justified for a nasal drug delivery. It's of our classical literature as well. So because we are already topping it, the what is the amavastha and the pakvavastha is tanutvam. Then the features of the amtishay subsided. The patient feel the nasal cavity is not filled with the secretion. Then you should go for a nasal administration of the drug. So this is the amavastha. These are endoscopic picture. This is endoscopic picture. Endoscopic, this is a CT. These two are CT scan. You can see the maxillary sinus filled of the ethmoid, filled of the polypoid growth. This is supposed to be the middle turbinate, and this is a polypoidal changes. There's a thick purulent discharge coming out. So the literature has not condoned, you can say, the usage of any kind of a drug in amavastha or acute phase of the disorder. If you want to do so in the pakva phase, start with the
Sir?
aqueous phase of the medicine. Yeah. Sorry.
PPT is
Yeah.
not visible.
PPT is not visible. Sorry. Okay, let me share it again. Now it's visible, ma'am. Hello. Hello.
No, sir.
Hello. Is it not visible?
No, sir, your PPT is not visible.
Oh, okay. Give me some time. Though it is saying that it is visible. Please check. Not coming? Not coming, madam? Okay. Hello. Is it visible now, ma'am? Hello.
No, sir, not yet visible.
Okay. Visible, ma'am, now? Hello?
No,
Hello?
sir.
Hello? No?
Sir, not visible.
Okay. Hello? Not visible, ma'am? Hello? Hello? Hello?
Sir, you're audible, but presentation is
Okay,
not
but
visible.
not visible. Okay, then I have to do it again. I'll log out for two seconds. It's some kind of a technical glitch, I think.
Okay, sir.
Okay. Screen share. So please let me know when you are able to visualize it.
Now you're visible, sir.
Okay. Thank you very much. Sorry for the glitch. Let me shift it and again expand it first. Enter option. Visible now?
Yes.
Hello?
Yes, sir.
Visible now? Okay. Audible also? Audible also? Hello?
Hello.
Hello?
Yes.
Audible also, na sir?
Yes, sir. You are audible. Your presentation
And
is
visible
on.
also.
Your presentation is
Is
also
on.
visible.
Okay, thank you very much, sir. Should we continue, sir?
Continue, sir. Please
Okay,
continue.
thank you. So, okay. So this will be the amavastha or acute phase of the illness. So you can use a aqueous phase of the nasal spray or a nasal drug in this form of the disorder, because it quickly mixes with the aqueous based nasal drops or nasal drugs. Quickly mixes with the periciliary layer, and the drug distribution doesn't overweigh the cilia also, and doesn't slow them down. So it can use in in the commencement of the pakvavastha, when the oil-based drops cannot be used. So of a fine powder is again are relatively less used, but it's a wonderful mode of drug distribution, because it is this fine powder is when the size is greater than 5 micron, it distributes a huge part of the nasal cavity, particularly in the middle meatus also. In the nasal drops and the nasal sprays, we are not able to penetrate the middle meatus area, but this fine powder is able to penetrate the hidden area of the nasal cavity. So let me show you a gamma camera image. You can do investigation for drug distribution by two ways: by doing endoscopy, like you can stain a nasal drop by a red color or a yellow color, then you introduce the nasal cavity in a proper position. Positioning is also very important. Head down position or classical Ayurvedic position with head leaning backwards, and various other positions are also described in the literature. So this is either you could do an endoscopy, or you can do a gamma camera technique also. The powder or the drug you are using is stained with a you can say dye, which is well taken by a gamma camera. So this is that in case of a drop, limited drug delivery is there. In case of a fine powder, katfal nasse, you can take a large area of the nasal cavity is covered. Spray has got a large area, then the drops, but not as large as the fine powder itself. This is a nebulizer. So this is a very famous study which is done in order to segregate or differentiate between the drug distribution in different forms of the nasyas or nasal drug delivery system. So these are some recommendations. Pakvavastha is absolutely reliable, and you can commence the nasyakarma at that stage, but should start with a aqueous based nasal drop. Avoid liquid based or lipoidal drug in allergic rhinitis and acute stage of the disorder. So next is the most important question, which primarily all beginners used to ask. So how come the nasal drops or nasal drugs do they enter into the paranasal sinuses? So this is a very important question. It is not easy to drugs to travel into the opposite direction of the beating of the cilia. So this is supposed to be the maxillary sinus. These are the cilia. The cilia will beat always, according to Stamberger. The beating of the cilia is genetically determined. It cannot be changed even after a surgery. If you open this hair, then the cilia will be towards the natural opening or ostium. So any type of artificial opening will not help. That's why the middle meatal enterostomy of the old times is such a big failure, because it keeps up the patient is coming back with thick and purulent discharging into the maxillary sinus, frontal sinus, etc. So the cilia will beat always towards the natural ostium, and the nasal drop or nasicum which you are using will not travel against this ciliary beating pattern and will enter into the nasal cavity. I'm not saying this. This is justified by various studies, about 17 studies. So let me take you to the cadaver dissection. This is superior turbinate. This will be cribriform plate. This will be the face of the sphenoid. This will be the sphenoid sinus. This will be the nasopharynx choana. This will be the choana. And these are inferior turbinate. Now I have removed this middle turbinate. Now I have removed the middle turbinate. This is inferior turbinate. This is, you can say, uncinate process, hiatus semilunaris. And this is bulla ethmoidalis. This will be the opening of the nasofrontal recess, and the sphenoid opens on its face, on the anterior wall. Now look at this, the frontal. How come the nasal drop will enter opposite direction into the frontal sinus and will distribute into the frontal sinus and will enter against the ciliary beating pattern? These are opening of different sinuses. The frontal sinus, this is the opening of the maxillary sinus. This is the opening of the posterior ethmoidal cell. This is the opening of the sphenoid sinus. So these areas are relatively hidden. This is not so simple. If you do a nasal drop in a sitting position, the drop will go like this, and enters into the oral cavity, and it will be spitted out or swallowed. So these areas are underneath this middle turbinate and are difficult to access, like straight away for a nasal drop or a nasal spray. And it seems to be, you can say, postulation that they are easily entered into the paranasal sinuses, but the literature do not support this mechanism. These are nasal cavity full of polyp, and this is a CT scan which also shows the same. How come the nasal drop are going to enter in this type of nasal cavity? So if you want to really do justice to the patient, especially in case of polyp, the nasal cavity is filled with polyp, you have to remove the polyp first, or in fact, interestingly, we have done various type of, you can say, different things in case of polyp also. We have also injected the polyp also with APM'S sharp, diluted APM'S sharp, in order to reduce the size of the polyp. So if the patient is having a type 1 pathology, type 1 is when there is allergic rhinosinusitis, then we can use Haridra, or you can say curcumin base. We are using it for so many years now. Type 1 or allergic response, then we are using curcumin dissolved in 100 ml, and we are washing the nasal cavity. If the patient is having a polypoidal mucosa, then we are washing the nasal cavity with APM'S Chartel after removing the polyp also. We are not doing, you can't do anything with this cavity. The nasal cavity is absolutely filled. There is no space to negotiate any kind of a nasal drop in this case. So okay. Next is, this is this is a very, very important research paper which shows how there is a drug distribution pattern in paranasal sinuses. and this is by Walsh Thomas, and these are the conclusion of this famous research paper. There is limited or no drug distribution in frontal and ethmoid sinus of any type of a nasal spray or a drop or a nasal wash. They do not enter into the sphenoid sinus. Harvey, limited drug distribution, but improves after surgery. Improves after surgery. Mains also, no drug distribution in unoperated case, and the distribution increases 40% after surgery. Gobbler 2008, limited or no distribution of, especially if the nasal cavity is full with polyp. With the polyp. These are also some substitutes. Excuse me. Hello. Hello. Ravi sir.
Yes, sir, you are audible.
No, sir, there is a mic on of some moderator or a participant, which is disturbing. You can see, sir. If you can see, sir. Thank you, sir. Thank you. So this is not a preferential position. If you do a nasal drop in this position, it will certainly go quickly into the oral cavity, and the chances of the drug effectiveness distribution will not be there. So this is a European position, very, very famously used in Europe, and the literature supports it, like Paparella, and even the Bailey also suggests that this position is better than this position, and this is a classical Ayurvedic literature position we are saying. So we have got numerous new method of drug delivery, like atomizer device, and you can spray the nasal cavity with very fine atomized mist, and this has got a deep delivery up to the roof of the nasal cavity or up to the sphenoid sinus face also. So this is also a very interesting device, and this is a, you can say, Pradhaman Nas, and the patient can do this on its own. This is the mouthpiece, and this is the this will go into the nasal cavity, and the patient can insufflate the drug into the nasal cavity by its own. And this is a powder drug delivery system. It is also available. It is now extensively studied also. This powder form of drug delivery is extensively studied nowadays also. We have got nasal gels also. So they do not have a post-nasal droop, aftertaste, a leakage or irritation. They sticks to the mucosa and has got a better absorption. So this is very important, like evidence-based approval of wisdom. What are the wisdom which our classical literature have used in order to propagate the Nasya Karam as such a successful treatment in the nasal, rhinonasal, and even beyond the CNS, the oral cavity. So it is a well vascularized surface they have chosen, and this quickly absorption of the drugs to the CSF through the neuronal pathway, transneuronal or paraneuronal, the drug distributes into the CNS. So Ashtang Hridaya has considered Thaler as the best form of the nasal drugs of the Nasyas, and this conspicuously has got a better absorption, this lipid based drugs, and most of the Ayurvedic literature also supports this. So the target organ of Nasya, as you can see, is not nasal cavity by and large. It is central nervous system disorders like Vak, Sangha, Swaropa, Ghat. Apart from that, you can use it for Dant Rog also, and various Shiro, Nasa, even the supraclavicular disorder. This is not meant only for the nasal cavity, and the target for the Nasya Karam is, to be honest, other than the nasal cavity. In many cases, you can see in CNS disorders, and even you can use it in Timir and Pakshma and Vartmagat rogas as well. So this is a new concept in which the nasal drops are replaced by a high volume nasal irrigation, and we are using this for 4 to 5 years now. we rarely use nasal drops, and post-operative and not even operated case, we used to give aqueous dissolved medication for nasal wash by a red rubber bulb or Higginson syrup, on numerous other you can say equipments are available for washing the nasal cavity, just like gel neti. This is like a gel neti. So this is a distribution pattern of a nasal drop. So you can see these areas, sphenoethmoidal recess and area superior to the superior turbinate. This area, roof of the nasal cavity, is not accessed by nasal drop, which can easily be done by a low pressure but high volume. These are low pressure but high volume and high volume. So we have got, now they have distributed into two parts: the Nasyakarma or nasal drug delivery system, low volume, which consists of nasal drops, sprays, powders, and aerosol, and high volume we have got nasal wash, irrigation, and lavage. So this is a new instrument which is introduced by Medtronics USA, and it is used to lavage or wash the inside the sinuses also. The tip can rotate to various angles, and it's flexible tip, and this can forcefully push saline and even drugs which are mixed into the aqueous solution, and the sinuses can be washed. This is a patent system. We have got a micro debrider, but this is called as hydro dissector, and it completely washes out fungus and other entrapped secretion from within the sinuses, and it uses a high speed aqueous solution to wash the paranasal sinuses. So now we are concluding my this presentation, but one or two cases for the junior colleagues we can discuss. This is a case one. A female patient comes with a excessive sneezing. Look at this supra tip crease, thin and watery discharge, and itching also. So what is supposed to be this case? This is supposed to be a allergic rhinitis. So these are the possible Nasyakarma or different type of nasal drops or sprays drops you can use. Oil based anutel, kushtadi tel, shunkyadi tel. In aqueous form of pipalyadi kwath nasya you can use, and in powder you can use satyadi churn nasya. All of the reference has been taken from the classical literature itself. This is going to be easy. So it's a 53-year-old poorly controlled hypertensive patient. The BP is shooting up, grade 3, and is currently on thinners, blood thinners like aspirin and clopidogrel and whatnot, warfarin, and for a deep venous thrombosis patient. He has got a multiple nose bleeding, and he has got an ulcerated mucosa in endoscopy, and the blood trickles in the throat. What is the diagnosis? It's not for the, it's only for the students. So this is sphenopalatine artery, which comes from the pterygopalatine ganglion. It's a part of it's a branch of the maxillary artery, and it forms about 80% of the blood supply of the nasal cavity. This is a posterior epistaxis. So the treatment you can offer is Brahmi grath, oil-based Vasagrath, very important for nasal installation or usage. Shatavari grath, Shir Bala tel. We are using this for many time now. Durva Swaras, which are decoction based, and in fine powder you can use Madhuyashtyadi churnal and Lodra. So this probably I will skip because of the time allotted to me is relatively going to finish now. So this is important. A male patient, 22 years, college student comes to you with a throbbing headache, a pulsatile headache with photophobia, phonophobia, nausea, vomiting, family history is positive, typically lasting episode from 4 hours to 3 days, and CECT and EEG are not significant. They do not lead to any kind of information. So what is this diagnosis will be? This has to be migraine, nothing else. Very common. 95% of OPD, headache OPD is supposed to be migraine, and the nasal drops. You can Dashmuladitel is very important, and Dhanvandraditel nasya decoction you can give him a Marange Soras nasya. Oh, sorry, Brangaraj. And can use Basharatnadi Shwasutharaj in our home, and it's so much that gives the patient instantaneous relief, like the sun destroys darkness. So this is again, next patient is a female kid.
Sir, you are not audible.
I'm audible now, ma'am. Hello.
Yes, sir.
Okay, I'm finishing now, ma'am. So this is an adenoid case. This is an adenoid case. And in the X-ray lateral view, you can see a huge soft tissue mass, which is hyperdense, just inferior to the sphenoid sinus. And this is supposed to be the adenoid or hypertrophy of the nasopharyngeal tonsil. You can use a Rasanjanadi telanus, and in aqueous frame, you can use Apamarg Shartel, Mradu, 3 gram in 1 cup of water. Then you can use for washing or douching purposes. So this is the take-home message from my side. So through my experience, I can say that but this endoscopy and radiological skills will definitely going to help, especially for the beginners also. In order to understand, you have to do hundreds of endoscopic diagnostic nasal endoscopy to understand how different type of disorders are represented into the nasal cavity, and how your treatment in terms of nasya is going to help in this patient. So the basic feature of arm and papakutadishya, which is elaborated in our classical literature, is absolutely reliable, and you have to follow it in letter and spirit. And you should not use oil-based lipid form of nasal drop in acute form of the disorder. You can start with aqueous base, then you can move on. And these sprays are better than drops, I can certainly say, because they covers large area. And the fine powder, which is also neglected in many senses, is it can be used for covering a large area of the nasal cavity. And the sound knowledge of endoscopy and radiology you can use for the sake of usage in your augmentation of your Ayurvedic sense of treatment also. And the patient are going to be helped in numerous and enormous ways. Thank you very much for the opportunity, and sorry for being such a long lecture. I have never presented such a long lecture. Thank you very much. Thank you.
The last slide was good.
Thank you, sir.
Thank you, sir. Informative lecture. Now I request our chairperson for the first session, Dr. Sarla Dudat ma'am, to kindly conclude the session.
Thank you, sir, for giving me this opportunity. Bharadwaj, sir, really very good lecture you have delivered with a scientific base. There are mucociliary clearance time also you have explained very well. All the points you have explained very well and practically and scientifically. The theory of nasya is irritation theory. It works through the irritation and then the absorption theory. It works through the absorption of the nasal drops and the drugs. Then you have explained very well the paracellular means the aqueous and slow and passive drugs means I think it is a slow and short acting, and the transcellular delivery, that is the lipophilic drugs means oil or ghee, it works slowly, but it is I think it is a long acting drugs. Then you have explained very well the avastha of the disease, when to use the nasya and when to not use the nasya, amavastha, pakvavastha, everything with the advanced instrument uses in the various places. Also, you have explained very well. Thank you very much, sir, for a very
Thank you.
nice lecture. Thank you.
Thank you, ma'am.
Thank you, Ravi sir. Thank you.
Yeah.
Thank you. I'm allowed
Thank
to
you,
leave, sir.
ma'am. Now we proceed for the second session. I request Dr. Govind Lihinar to introduce a speaker for second session, Dr. Sunita Magar, ma'am.
Good afternoon, everyone. It is a pleasure from me to introduce our speaker today, who is going to talk to us about a comprehensive Ayurvedic approach on tinnitus. This is a subject in which we should all deeply interested, because nowadays it is common problem in patients. Our speaker, although having spent almost her entire career to treating management of tinnitus through Ayurvedic approach, Dr. Sunita Magar, madam. MS in Shalakya tantra and MD in Bhaishya Ratnavali and Rashastra. She is a gold medalist, professor, Department Shalakya tantra. She is an ex-chairman, Board of Study and Academic Council member, DMIMS. Research paper publication and presentation at national and international conference at Abboud, Colombo, Sri Lanka and Romania. She is an ex-chairman, Board Study and Academic Council member, NAC Accredited Plus A. NAC Coordinator Criteria 2 at GD Pol Foundation's YMT Ayurvedic College and Hospital. She is having the Fellowship Coordinator at GD Pol Foundation YMT Ayurvedic College. She is a winner of Nagarjuna Award from Herbal Academy, Vijayawada, Andhra Pradesh for the best dissertation all India level. More than 20 presentations in the national and international conference. 27 years of academic and clinical research administrative experience. Now I request to one of the greatest personality, Dr. Sunita Magar madam, to start our today's topic. Thank you.
I request Dr. Ram Avatar Gupta to kindly introduce the chairperson of second session, Dr. Deepak Sawant, sir.
Hello.
Yes, sir. You are audible.
Am I audible, sir? Hello. Am I audible, sir?
Yes, you are audible, Ramautar. Please
Yes,
go
sir.
ahead.
Good afternoon to all. I would like to introduce the chairperson for the second session of the webinar, Dr. Deepak Sawant, sir. Sir is a professor and HOD of Department of Shalakya Tantra, Government AYURVED College, Osmanabad. Sir has completed his UG and PG both from the Government AYURVED College, Nanded. Sir has a teaching experience of 20 years. Sir has worked as an Ayurvedic expert in Ayush camp organized by the National Rural Health Mission at Sangli district. Sir is a subject expert and examiner. Sir has participated in various national seminars and workshops, and also worked as a co-chairperson and coordination in various webinars arranged in throughout the country. Also, sir has published various research articles related to Ayurveda, and also especially in the Department of Shalakya Tantra. One of these famous articles published by this sir is efficacy of the Triphala Growth in Netrapan in the management of computer vision syndrome, which was published in the Ayurlog, which is published in the ayurlog.com, also available at the International Journal of Research in Ayurveda and Pharmacy, which was published in March and April 2013. I welcome you, sir, for this national webinar.
I request ma'am to kindly start with the lecture.
Hello, good afternoon, everyone. Am I audible?
Yes, ma'am.
Okay, sir. Good afternoon. I am Dr. Sunita Magar. That Dr. Govind has just now introduced me. I am professor in the Department of Shalakya Tantra in the Dr. G.D. Paul Foundation's YMT Ayurved Medical College, Kharghar, Navi Mumbai. And today's topic, I would like to welcome audiences who are connected online with me, organizers, SION Ayurved College, More sir, Dudhmal sir, and whole team and my respected teachers also who are might have connected with me online today. So before starting this tinnitus, the most irritating and annoying disease. So shall I start with a slide share, sir? Shall I start with slide share?
Yes, ma'am.
Okay. So this is the comprehensive Ayurveda management, comprehensive Ayurveda approach on tinnitus that we call as a Karnanada, which is well elaborated and well described in Sushruta Uttar Tantra, chapter number 20, 21. Both chapters are devoted exclusively for Karna, diseases of Karna Roga. And then latter 22, 23, 24. This is elaborated for this is exclusively dedicated to NASA. So as far as today's topic is concerned, this is how annoying ancient treatment modalities. Today, I would like to throw light on ancient treatment modalities. All of you know, all we are practicing. And today's lecture, I have a plan considering my UG student and PG student, because when I have seen the list of the participants, most of the UG and PG students are listening. So this is for them, and they should have a faith in Ayurveda, and they should understand the limitations of the ENT surgeries also, because I have compared the ENT surgical management and the same way, same time simultaneously when I treated the tympanic with our Ayurveda management. Then I had the faith, and I should practice more on Ayurveda rather than running after that particular surgical approach. So those ancient treatment modalities, this is the unimaginable and unbearable. See how annoying this tinnitus might be, because when listens to its own voice, and there is a noise when we stuck into the traffic and we cannot bear the noise pollution. The same way, there is an internal noise the patient can hear himself. So this is unimaginable and unbearable. So for my UG student and PG student, this is the brief anatomy of outer ear, middle ear, and inner ear. As far as this tinnitus disease is concerned, the cochlear nerve or inner ear is worst affected part. So this cochlear portion on this inner ear, when the sound wave pursues from the outer ear, later we will deal how this sound waves transmitted to the cochlear nerve, and then cochlear nerve gives a signal, reaches to the brain. So this is for my UG and PG students. So this is the semicircular canal, and again this is the semicircular canal. This endolymph plays an important part to this endolymph. The signal reaches to the cochlear now. So as far as the physiology of hearing is concerned, as far as the faculties are concerned, they might know, but whenever there is a sound waves strikes on the pinna, or pinna perceives this, collects the sound waves, and then it transmits towards tympanic membrane, or sound wave strikes on the tympanic membrane, vibration created on tympanic membrane, and this vibration transmitted to the transmitted towards the ossicular chain. All of you know ossicular chain, the three middle bones, stapes, incus, and handle of malleus, and through this ossicular chain, this sound waves transmit and through the whole window vibration of stapes of foot plate, last bone which is connected with the vestibular part. This is the and causes pressure, exert pressure, and that could endorse the changes into the labyrinthine fluid. That endos the changes into the labyrinthine fluid. It is called endolymph also. And these changes which occur into the labyrinthine fluid or endolymph causes the movements of basilar membrane. All of you know anatomy as the faculties are concerned. This is for my UG students. I'm telling you the detail. So physiology of hearing. So causes movements of basilar membrane, and then it stimulates the organ of Corti. Organ of Corti is stimulated, and this convert mechanical energy into electrical energy. Up till now, this organ of Corti is stimulated. This energy is up to the, it is a type of mechanical energy. And this mechanical energy, it will be converted into electrical impulse. Just now we have seen the lecture of Dr. Atul sir, and he was explaining and elaborated well the nasal drug delivery system. So I would like to tell them, sir, ki NASA or nasal drug delivery system is not only restricted to ENT or eye disorders, but it is having a great canvas, bigger canvas. PCOD, secondary amenorrhea, amnesia. There are n number of nasal drug delivery systems. We should not restrict our Karna Purana Nasya or that kind of procedures to particular Udhvajatrugat Vikara. It is having a larger impact on whole our body. So physiology of hearing, impulses carried, this impulses converted into electrical, and this electrical impulses carried away by auditory nerve, that is a vestibular nerve, and goes to the hearing center, which is situated at the temporal lobe. This kind of physiology of hearing everyone might be aware. So tinnitus can be frustrating amount of reason. First, what is the first thing? It is a subjective phenomena. अभी आप लोग कहेंगे भाई tinnitus tinnitus, I'm talking about subjective tinnitus. The patient feels, it is a perception most of the time, like hallucinations. When we see कि this is hallucination, भाई उनको दिखाई दे रहा है, हमको नहीं दिखाई दे रहा है, ये उनका imagination है. So as far as the tinnitus, case of tinnitus is concerned, patient perceives or patient hear the sound or noise, but at the same time, objective, when we are an observer, we cannot hear the sound, what the noise, what the patient perceives. So this is called subjective, and 90% of cases are of subjective tinnitus, where when patient himself can hear the noise, nobody else. And so objective tinnitus is concerned where the patient or other observer might hear the sound. So second, there isn't any one true objective way to measure tinnitus. So if it is objective, ठीक है, अगर पेशेंट को सुनाई दे रहा है और साथ साथ अगर ऑब्जर्वर को भी सुनाई दे रहा है, there is no specific method till date कि बाबा we can parameter, we can instrument that we can measure the tinnitus. So unfortunately, you can't just get up and go into your doctor office or get some blood drawn के blood test कर दीजिए, कितनी blood sugar बढ़ी है देखो बरा, brain कर लीजिए बरा, मुझे tinnitus की तकलीफ हुई है. That kind of liberty you don't have as far as this tinnitus case is concerned. Tinnitus is a very tedious type of disease. So definition, though it is a tedious type of disease, we can't leave the patient. So we will have to accept the challenge. So tinnitus, what is tinnitus? It is the description of noise inside a person's head and in the absence of auditory stimulation. See, there is no auditory stimulation. बाहर कोई नॉइज है ही नहीं, बाहर से कोई नॉइज आपके कान तक पहुंच ही नहीं रहा. स्टिल यू परसीव, स्टिल यू फील, स्टिल यू हियर द नॉइज इनसाइड यू. सो दिस इज कॉल्ड tinnitus. A condition that can result from a wide range of underlying cause. So what is tinnitus? Again, this is the perception of sound, different definition, absence of any external input, and the person is unrelated to any external source. Again, symptoms can be unilateral, bilateral, present with or without hearing loss. So tinnitus and sensorineural deafness are very closely associated with each other. The patient who is suffering with sensorineural deafness might feel the tinnitus, might have attacks of tinnitus, or a patient who is suffering with tinnitus, in later stage, it will further degrade his hearing capacity. So अगर पेशेंट को पहले tinnitus हुआ है, बाद में उसको sensorineural deafness हुआ है, sensorineural deafness हुआ है और later on उसमें another complication add हो गया कि उसको अभी बार-बार noise भी सुनाई दे रहा है. That is called tinnitus. The symptoms can be unilateral, bilateral, present with or without hearing loss, and resembling what kind of sound patient will perceive or hear. Say ringing, hissing, whistling, humming, buzzing, chirping or clicking. That kind of the description of the sound is explained. So prevalence. So why this topic is important? Because all of you know, whenever we take a particular prevalence, बाबा, all over world में, इंडिया में कितने सारे केसेस है आए हैं. तो हम लोग को जो right now all of you have seen this epidemic is going on, or epidemic with large sample size, lakhs patients are involved. So prevalence is very much important as far as this clinical study or research study is taken up. So prevalence is right from 8% to 25% of the US population, and 4.6% to 30% of tinnitus in other countries. So this is the severity of the prevalence. So it's a very high time that Ayurveda and other alternative sciences should step in into particular treating the tinnitus patient, because patients are very much fed up. So symptoms and causes. So tinnitus is often considered idiopathic. The most likely causes can be determined from the case history and patient symptom is age-related hearing loss, presbycusis, जो after above 60 years के जो लोग होते हैं, and noise exposure stay, the foremost common cause. If a person, particularly is exposed in a lot of noise pollution, if the person is working in the, what I would say, in the factory or welding shop or wherever, when there is a hammering sound, a lot of sound waves more than 85 decibel, if it crosses the limit of more than 120 decimal, and these ears are exposed to such a loud noise, exposure to this noise, then definitely there will be the degenerative changes occur, and this tinnitus patient will start giving the symptoms like noise in the ear. So facts, what are the facts? So bewitched ear, worm in the ear, acoustic hallucination. Then treatment remedies for tinnitus date back to the era of Aristotle, who proposed masking tinnitus with an external stimulus as remedy. Right now, I would like to throw a light in brief ki everyone should know what is the modern concept, what is tinnitus, Baba. वो लोग क्या सोचते इसके बारे में, what is their thinking and their point of view and their line of treatment, and where they are lacking and where the role of Ayurveda starts with. So these are the facts. So worm in the ear, bewitched in the ear, and acoustic hallucination. So कुछ लोग तो बोलते हैं hallucination ही है, ऐसा कुछ noise वगैरह है ही नहीं, आपको कोई psychological problem हो गया होगा इसलिए आपको आवाज सुनाई दे रहा है, because there is no specific instrument to measure the noise. So ट्रीटमेंट रेमेडीज ऑफ tinnitus, अगर एरिस्टोटल के एरिया में जाते हैं हम, तो वहां पे मास्किंग ऑफ tinnitus मींस उन्होंने क्या कहा था, जस्ट टू मास्क द इंटरनल नॉइज and or divert your attention or your brain towards the external noise. So types of objective and subjective. In some cases, others can perceive that. Just now I told you what is objective. When observer can hear, or objective tinnitus can arise from the muscle spasm or vascular in origin. And subjective means the most common cause is noise induced, ototoxic induced, and hearing loss. See, when a patient is on ototoxic drug, all of you know this, streptomycin, chloroquine phosphates, there are certain steroids, antihypertensive, antidiabetic drugs, there are n number of ototoxic drugs are discussed. We will later on see the list of the ototoxic drug also. When a patient is on ototoxic drug, definitely there will be the atropic changes occur into the cochlear nerve and whole internal ear structure, and then a patient might start with a noise that is called tinnitus. So ototoxic drug and drug withdrawal in both the types. So how sound injurious to cochlear nerve. So what is loud? What is loud and what kind of sound is injurious to cochlear nerve? So see, normal conversation is about 60 decibel. All of you know, up to 60 decibel, when we talk normally one to one face to face, अगर आप सामने बैठे हो एक दूसरे के पास और आप बात कर रहे हो, तो हमारा कॉन्वर्सेशन होता है 60 डेसिबल में. दैट इज परमिसिबल कि हमने बात ही करनी चाहिए कि 60 डेसिबल तक हो अपना कॉन्वर्सेशन का फ्रीक्वेंसी ऑफ साउंड. देन साउंड एट और बिलो 70 decibel generally considered safe. So it is considered safe, 60 or 70. Any sound more than 85 decibel is most likely to damage your hearing over time. If your ear are exposed to the sound more than 85 decibel, that too consistent whole day, then definitely And I am telling you why I am describing all these things, because this plays an important role in the tinnitus. Whenever we take the history of tinnitus, you should have a thorough history of tinnitus of what the patient is facing. So then damage occurs to the inner ear after people experience one signal, extremely loud noise like a gunshot. देखिए आपके कान के पीछे बंदूक लगा के शॉट करेंगे, गन शॉट करेंगे क्लोज टू ईयर और अ लाउड नॉइज ओवर अ लॉन्ग पीरियड ऑफ टाइम. सो इट्स अ कॉम्बिनेशन ऑफ बोथ थ्रेशोल्ड एंड ड्यूरेशन. जब गन शॉट करते हैं आपके ईयर के पास एंड ये जो वॉइस साउंड होता है, डू यू नो इट इज मोर देन 140 डेसिमल एट अ शॉट, एट अ ग्लांस. अगर आपको गन शॉट कर दिया जाए तो आपका हियरिंग कैपेसिटी परमानेंट डैमेज occur to the cochlear nerve because it will cross the limit of 140 decimal. So gunshot voice. Then crackers का भी कभी दिवाली में पटाखे हम करते हैं या बुलशॉट का आवाज आता है. Extreme trauma where the decimal crosses from 140 or 150 onwards. So sound injurious to cochlear nerve. See, just 140 decimal noise for a second is very injurious, and 100 decimal noise for a second is not injurious, but over a period of several hours. See, अगर 100 डेसिमल 85 डेसिमल का आपको एक्सपोजर हो रहा है, लेकिन अगर एक सेकंड के लिए 100 डेसिमल का एक्सपोजर होगा, so it won't affect your hearing capacity. But if your ears are exposed, दिन भर आप 100 डेसिमल का आवाज सुन रहे हो, कान में ईयरफोन डाल के बैठे हो. Nowadays younger generation is going crazy and they are taking this is a earphone, and then they are continuously work from home and that kind of online culture and hearing music in too loud music they are hearing, and ears are exposed. Though the frequency of wavelength is 85 decimal or 100 decimal, but if they are exposed for longer period of time, that would be an injurious to their ear. So causes. So I am talking about I am trying to throw light according to modern science, what could be the causes for tinnitus. So ear problem and how we can correlate this modern science, what has elaborated these causes with our Ayurveda. Ayurvedaचं काय म्हणणं आहे that we would correlate with this modern science. So ear problems, neurological disorders, psychiatric problems, disorders, metabolic disorders. See, the metabolic disorders plays a very important role. Thyrotoxicosis किंवा hypothyroidism है, और there are n number of metabolic disorders. जैसे diabetes, I told you diabetes is the culprit, hypothyroidism is the culprit. Endocrine disturbances lead to the tinnitus. So you will have to be very keen towards the proper history taking of the patient. So history taking is most important as far as the Ayurveda consultation is concerned. So ear problems, neurological disorders, psychiatric disorders, metabolic and miscellaneous. So this is condition. What are the category of ear problems? Neurological है तो क्या है? Metabolic disorder में thyroid, hyperlipidemia, vitamin B12 deficiency, iron deficiency. Psychiatric में depression, anxiety. So in ear problems, अगर देखिए आपको otitis externa है, otitis media है, and then your ear are exposed to this middle ear bony ossicular chain is affected, sclerotic changes occur into their middle ear, and definitely there will not be transmission of this sound waves properly to the throat stapes. Just now I told you that throat stapes into the oval window, this sound waves transmits from mechanical energy, and how this mechanical energy is converted into electrical energy. If there is earwax present, if there is a discharge or infection present, or noise induced Meniere's disease, acoustic neuroma, mercury or lead poisoning, ototoxic medicines. So this kind of PPT is in front of you, that n number of numerous causes. Along with that, miscellaneous, this miscellaneous causes means you can concentrate on there n number of causes. It is very difficult to summarize what could cause the tinnitus. देखिए, अगर आपको पेशेंट की ट्रीटमेंट प्लान करना है, चाहे आयुर्वेदा हो चाहे मॉडर्न, दिस लेक्चर आई एम right now I'm delivering this particular lecture and I am talking the patient's points of view perspective. So ये कोई थियोरी में आपको एग्जाम में लिखना नहीं है. मैं यूजी और पीजी स्टूडेंट को बताना चाहूंगी, बच्चों को, कि जो अपने पास ओपीडी में पेशेंट आएगा, so then you will have to think about cellular level. In that case also patient feels the pulsatile tinnitus. These vibrations are transferred to the fluid in the cochlea causing tinnitus. All of you know this. What happens? The most common is idiopathic intracranial is hypertension caused by elevated intracranial pressure that transfer pulsation through the cerebrospinal fluid. Vascular structure, just now sir told you how the nasal drug delivery reaches particularly aqueous type into the cerebrospinal fluid through cribriform plate and cerebrospinal fluid. The same way, this endolymph and this cerebrospinal fluid, this sound perceptions or vibrations reaches transferred to the fluid in the cochlea, that is called endolymph, labyrinthine fluid. त्याच्या थ्रू आपल्याला CSF fluid पर्यंत त्याचे vibrations जातात. So unilateral tinnitus might also result from chronic noise exposure, that just now I told you, semicircular canal dehiscence or acoustic trauma. बघा, कानाला जर इंजुरी झाली असेल, ऍक्सिडेंट झाला असेल, while careful history taking, if there is an injury to the your head or injury to the parietal side, temporal side, so then in that case also the unilateral tinnitus patient might feel. So bilateral tinnitus is most commonly caused by age related hearing loss, noise exposure, and otosclerosis. I told you the causes of otosclerosis: when there is a conductive deafness and there is infection reaches to the middle ear through the eustachian tube, and then otosclerotic changes occur into the middle ear. That otosclerotic changes might cause the tinnitus. So evaluation, how we are going to evaluate them? Diagnosis, severity, and auditory evoke responses. अगर पेशेंट हमारी तरफ आता है और वो बोलता है कि मुझे आवाज सुनाई दे रही बार बार, हम लोग उसको रीडिंग स्टेज, वेबर स्टेज करके we will refer the patient for auditory evoke responses, that is audiometry. Then we will categorize the patient, severity of the patient we will see after proper history taking, after objective criteria. So even auditory evoke responses, even audiometry won't reveal what could be. The audiometry will only reveal where there is a degradation in terms of hearing loss. When there is a hearing loss, that audiometry can find out. So otoscopic evaluation and audiometry, these are the two important parameters of evaluation we use. But as I told you that this tinnitus, when patient hears the sound, cannot be tapped, cannot be captured by any instrument or any instrument as such कि बाबा नहीं हम उसकी velocity और कम से कम frequency तो भी कम से कम tap कर सके with particular instrument. So measuring a hearing acuity and pure tone, all of you know speech, pure tone and impedance, and this kind of audiometry will reveal the your deterioration in terms of hearing loss, and not the volume or capacity or degree of tinnitus the patient is suffering. So this is the hearing loss, subjective or objective validated self-rato. A classification of the degree or hearing impairment, ability to perceive the sound. When difficult to identify soft sounds such as whispering, and moderate, unable. What happens जब patient continues ये complaint करता है years together कि डॉक्टर साहब मेरे कान में आवाज, बरसों से कान में आवाज सुनाई दे रहा है, और मुझे पहले तो केवल यही शिकायत थी, लेकिन अब तो मुझे आप बात कर रहे हो वो भी नहीं सुनाई देता है. So later it will affect your hearing capacity. The hearing capacity is affected because of tinnitus, or because already hearing capacity is affected and later stages tinnitus is started. So mild, moderate, and moderately severe and severe. So this kind of classification of the degree of hearing impairment and ability to perceive sound is given below. So profound means difficult to perceive any sound, and severe can only hear very loud noises and sounds such as shouting or vacuum cleaner. Severe hearing loss कब कहेंगे? जब उसको vacuum cleaner का noise ही सुनाई देगा, बाकी कुछ भी नहीं सुनाई देगा. बाकी तो उसको हम उनके साथ में बैठे हैं वो भी conversation उसको सुनाई नहीं देगा. Unable to clearly hear loud noises such as telephone ring also. So these are the latter the complication of tinnitus itself. So hearing impairment. If there is something not working in the ear canal, eardrum, middle ear, bones, or middle ear space, it may get result into conductive hearing impairment called mechanical hearing impairment. If on the other hand, sometimes it is not working, cochlea, auditory nerve, or brain, it is most commonly result in sensorineural hearing impairment, which is also cause of a tinnitus. So mixed hearing impairment or sensorineural hearing impairment goes hand in hand with tinnitus. So tinnitus associated when patient affect on following career development parameters. What would happen to the patient? अगर पेशेंट को सुनाई नहीं देता है या पेशेंट को कंटिन्यू आवाज ही आ रहा है, सुनाई दे रहा है उसका कान में, सो लैंग्वेज, Though what will be the percussions on the patients? Career development parameters ये survey किया था, तो delayed language development with unclear speech or incorrect pronunciation. Then emotion and behavioral changes patient में आएंगे. Easy to have emotion and behavioral problems such as result of difficulties and variably expressing himself. आपको पता है मेरा YouTube पे वीडियो है sensory deafness and management with Ayurveda. Patient find it difficult to communicate and patient feels ashamed. Patient feels very awkward to accept that he is not or she is not able to pursue the sound or she can't hear. When a patient is easily accept कि उसको दिखाई नहीं देता, as far as the hearing capacity deterioration is concerned, patient never go to the physician. It is hearing is impaired, is observed phenomena by the others. हम नोटिस करते हैं कि पेशेंट को सुनाई नहीं दे रहा है, जबकि हमें दिखाई नहीं देता है, तो पेशेंट खुद होके चश्मे का नंबर निकालने के लिए आते हैं. They don't feel ashamed while going to the ophthalmic surgeon and taking the asking for the glasses or accepting that they are can't see. But as far as the this hearing capacity or deterioration of the sound is concerned, they feel ashamed, and all others hearing impairment is noticed by others. और हम बोलते कि आपको कम सुनाई दे रहा है क्या, तब वो बोलते कि यस यस ठीक. सो सेल्फ कॉन्फिडेंस डेफिनेटली वो कट जाते हैं सोसाइटी से, बोलते इनको तो सुनाई नहीं देता, इनसे बात करके क्या फायदा है, उनसे तो ऊंची आवाज में बात करना पड़ेगा. तो सेल्फ कॉन्फिडेंस, सोशल इंटरेक्शन, एकेडमिक परफॉर्मेंस, लैंग्वेज, everything will get affected as far as this hearing of impaired hearing is concerned. And I already told you this impaired hearing goes hand in hand with tinnitus. So diabetes is the culprit. Diabetes is the culprit. I told you that when there is a craving of insulin, just like diabetic retinopathy, there are degenerative changes occur into the cochlear nerve. So because of the metformin and glibenclamide, the diabetic anti-diabetic medicines we are using, or because of diabetes itself, it is causing tinnitus because cochlear nerve degeneration उसमें होता है. Out of as main etiological factors related to is hearing impairment, tinnitus, and dizziness. Therefore, the diabetic population must be considered at high risk for auditory conditions. और आप अगर डिटेल हिस्ट्री लोगे तो आपको डायबिटिक और either they are on anti-diabetic medicine or they are diabetic since so long. So management, again these modes of management, sedation. वो क्या करते हैं? वो क्या करते हैं कि बाबा साइकोथेरेपी करेंगे, मास्किंग करेंगे, रिलैक्सेशन करेंगे, सेडेशन देंगे, एंजाइटी एंटी एंजाइटी ड्रग देंगे, एंटी डिप्रेसेंट ड्रग देंगे, मास्किंग मैन्यूअल्स एंड डिवाइसेस. मास्किंग करते हैं ईयर्स का सो दैट अंदर की आवाज सुनाई न दे. देन प्रिवेंशन, मेनली इट इंक्लूडिंग 3 levels. इट इज एम्ड एज मिनिमाइजिंग द रिस्क ऑफ ट्रॉमा. ये सब चीजें अगर हम देख रहे हैं तो व्हाट कुड बी as Ayurveda, as our today's topic is Ayurveda management, so Ayurveda believes in prevention. The first step I would advise, we should prevent this tinnitus and this kind of sensorineural deafness and deafness scenario. So it at primary level it is aimed at minimizing the risk of trauma. हेलमेट पहनी है या ट्रामा के रिस्क मत लीजिए, नॉइज एक्सपोजर में मत रहिए, डीजे लगा के डांस करना, हेडफोन डाल के रखना, लॉइड आवाज में म्यूजिक सुनना. सो यूज ऑफ ऑटोटॉक्सिक ड्रग, अगर आप फैक्ट्री में काम कर रहे हैं, वेल्डिंग मशीन में काम कर रहे हैं, then you should cover your ear properly so that there should not be a mechanical trauma occur to their tympanic membrane perforation. Later on this your cochlear nerve degeneration occur. So as far as the Ayurveda consultant is important from the Ayurveda consultation point of view, that we should be a good counselor. We should counsel the patient and counsel the society that first is you should concentrate on preventive measures. So these are the वैक्सीनेशन करना है, मीजल्स, मम्स एंड रूबेला. बिकॉज ऑफ मीजल्स, मम्स, रूबेला इसके वजह से भी आपको डिजेनरेटिव चेंजेस आता है. पीरियडिकल हेल्थ चेकअप इज मस्ट. Exposure to noise level in excess of 80 decibels throughout 8 hours per day is considered as excessive and should avoid. So 80 decibels को अगर दिन भर अगर मैं आपके साथ अभी बात कर रही हूँ और दिन भर my ears are exposed to 80 decibels, then definitely that will deteriorate my health of my cochlear nerve. So in addition, teenagers need to be aware. I would appeal to the teenagers who are listening and watching, connected with me, they should protect their ears. And they should not expose their ears more than 80 decibels. Every 60 decibel is enough. So loud music is concerned, that should be an enclosed spaces. देखो आप डीजे लगाया है, आपने अपने क्लोज रूम में लगाया है और आप ग्राउंड पे लगाया है, दैट्स अ लॉट ऑफ डिफरेंस. सो यू शुड अवॉइड एनक्लोज स्पेसेस. सो ऑक्यूपेशनल और इंडस्ट्रियल वर्कर्स जो है वो भी उनको ईयर प्लग्स पहनना चाहिए. जैसे मैंने बताया कि अभी उनका प्रोफेशन है, जॉब है, जैसे डिजिटल आई स्ट्रेन का लेक्चर लिया था मैंने, उसमें बताया था आपको कि हाउ वी कैन प्रोटेक्ट अवर आईज बिकॉज इट इज इनएविटेबल नाउअडेज. वी हैव टू स्पेयर 8 to 10 hours on computers. So same way, if the industrial workers who are working in the company or in the factory, they should properly put a earplugs so that they can avoid the trauma. Then sound therapy. What is sound therapy? The modern science क्या करते हैं? Sound therapy मतलब external sound to mask the internal sound of tinnitus. Sound therapy is the use of external sound. जैसे आप if you are listening, अगर मैं internal noise सुनाई दे रहा है मुझे, if I am a patient of tinnitus and I am feeling or perceiving lot of internal noise, so what this modern science try to do, they put an external जिसको बोलेंगे impulse or environment, noisy environment around you. In order to that, patient will divert towards the external noise and patient would forget the internal noise which is occurring. So but this is called a masking. Then take a action. tinnitus retraining therapy, उसमें TRT भी करते हैं. TRT करते हैं is effective quite a bit, but to habituation on both fronts, both in terms of the actual sound and in terms of the emotional and behavioral response. देखिए अगर आप बोलते हैं कि बाबा हमको आवाज बहुत सुनाई दे रहा है अंदर, यानी पेशेंट टिनिटस का जब आता है तो उसको रात में ही ज्यादा टिनिटस सुनाई देता है, दिन में कम देता है, क्योंकि बाहर नॉइज है, एटमॉस्फेयर में देयर इज अ लॉट ऑफ नॉइज in the surrounding. So his ears try to perceive that sound waves, and in that process patient forgets brain signals. Brain को जो signal मिलता है, after all this is the brain signal reaches to the brain. When patient का diversification हो जाएगा towards external sound, तो patient का जो internal noise है patient will feel less. So वो इंटरनल, जैसे हम डिसेंसिटाइज करते हैं, हम लोग क्या करते हैं, जो ऑपरेशन करते हैं तो एनास्थेसिया देते हैं, पेन है लेकिन हम डिसेंसिटाइज कर देते हैं पर्टिकुलर पीरियड ऑफ टाइम. सो डिसेंसिटाइज करेंगे तो आपको पेन फील नहीं होगा. द सेम वे व्हेन यू विल डाइवर्ट योर ब्रेन टुवर्ड्स द आउटर नॉइज, देन डेफिनेटली दैट वुड हेल्प टू सर्टेन एक्सटेंट टू योर इंटरनल नॉइज. बट उससे क्या होगा, कॉक्लियर नर्व का डिजेनरेशन तो ठीक नहीं होगा. ठीक है. सो द मैनेजमेंट विथ मॉडर्न साइंस, special hearing aids, electronic masking devices, this kind of lidnocate directly into the inner ear are also being used in some cases. The cochlear implant, cochlear stimulation devices are being investigated for severe intractable tinnitus cases. So cochlear implant और cochlear stimulation devices भी डालते हैं. Surgical injection जो lidnocaine के मैंने बताया कि desensitize the particular directly into the internal ear are also being used in some cases. So this kind of thing, masking of the devices, electronic masking of the devices, ये सब चीजें वो करते हैं. So pharmacotherapy, ये तो मैकेनिकल हो गया. आई एम टॉकिंग अबाउट फार्माकोथेरेपी. तो एक्यूट टिनिटस का अगर पेशेंट है तो वो लोग क्या करते हैं, मॉडर्न साइंस इज डू कॉर्टिकोस्टेरॉइड्स. फेवरेट लाइन ऑफ ट्रीटमेंट इज कॉर्टिकोस्टेरॉइड्स, ड्रोट्रोपिक्स, लिडनोकेन. Rheological therapy, local therapy, again corticosteroids are injected into the middle ear. So chronic tinnitus, then patient को antidepressant, anticonvulsants और glutamate receptor antagonist पे डालते हैं. So this kind of pharmacological preparations they are having. Others, vitamin tablets, multivitamins, steroids, antioxidants, furosemide, paraxamide, misoprostol, that kind of beta histine, this kind of medications or pharmaco products the ENT surgeons are using. So psychotherapy and reassurance, this kind of thing. So till date, this is according to modern science. But how Ayurveda will approach it. The second part of lecture, we would focus and we would concentrate how Ayurveda can cure. Yes, I am talking about cure. I am not trying to cover. Cover means हमें कोई चीज नहीं आती तो अंडर द कारपेट डाल देते. स्मेल आ रहा है, कोई अंडर द कारपेट डाल दो, मास्क कर लो, बंद कर लो. दैट काइंड ऑफ अप्रोच आयुर्वेदा डोंट बिलीव इन दिस काइंड ऑफ अप्रोच. आयुर्वेदिक पर्सपेक्टिव क्या है आयुर्वेदा का अप्रोच? सो these are the key herbs. These are the key herbs. I cannot have all the pictures or all the diagrams of key herbs, but the key herb is ashwagandha, Vidania somniferia. This first one is, and this is the these are the prayojang or parts use of ashwagandha is considered. This is the bilva, Marmelos egalis, and this is the dashamula. This kind of dashamula, ashwagandha, and bilva ditel, all of you know, ashwagandha you know, dashamula ditel you know. So we need to believe on our science. When we believe, when we have 100% faith, then and then only we can go for research and experiment. We might not be 100% correct, but there is no solution till date as far as the tinnitus is concerned. So the ashwagandha, bilva, dashamula, Ayurveda plays. Shalakya tantra mainly deals with the preservation and restoration of the health of the indriyas. This is the important shrotrendriya, dosha dusha. इसमें क्या आयुर्वेदा क्या बिलीव करता है? Not only preservation but restoration of the health of indriyas. Am I audible, More sir?
Yes, madam.
And my slides are clear, no? Sound
Yeah,
and slides? Okay.
Yeah.
So preservation and restoration of the health of the indriyas. We would concentrate on the health of the indriyas, how we can improve the health of the indriyas. So Karnanada is a Karna Roga studied under Udvajatraktikara. I know this is a very basic information I am providing, but my UG students are also watching this program. So that's why what is Karnanada they need to know. So the term Karna refers to organs which are responsible for the perception of the sound, includes external, middle and internal ear. The term nada means ninada, refers to that which produces rhythmic sound. जैसे टेलीफोन की पुराने जमाने में फोन रहते थे, उसकी घंटी बजती है, उस तरीके के sound. So according to ancient literature, what could be the cause? See, shrama, kshaya, ruksha bhojana, then vikrita shirshaya shita avasena, then shita rutu. So particular climate is responsible. When we consume lot of cold drinks or this kind of excessive physical stress, all these from A to F, right from Shrama to Shita Rutu. These things including environment and consumption of all kind of these things and Ruksha Bhojana. मुझे बताइए, अगर पेशेंट का हीमोग्लोबिन 5 मिलीग्राम है या रक्त धातु ही नहीं है, उसका रसद धातु रक्त धातु ही नहीं है, तो उसको कम ही सुनाई देगा. पेशेंट, मेरे पास भी पेशेंट बहुत आते हैं, वो कहते हैं कि मैडम हमको सुनाई नहीं देता, अगर उनका हीमोग्लोबिन 4 ग्राम है हमको दिखाई नहीं देता, आंखों के सामने अंधेरा आता है. अभी अंधेरा आता है तो आंखों के डॉक्टर की तरफ जाते हैं, लेकिन उनका आंखों का अंधेरा आने का कारण क्या है कि दे आर हैविंग अ वेरी रक्त धातु रस धातु ही पुष्टि नहीं हुई है, देयर हीमोग्लोबिन इज वेरी लेयर, ऑक्सी हीमोग्लोबिन ही नहीं हो रहा है. तो रुक्ष भोजन, वातवर्धक अगर भोजन हम पेशेंट करेंगे तो डेफिनेटली इट विल नॉट अफेक्ट, इट विल डेफिनेटली हैव अ परकशन ऑन योर hearing capacity. So this kind of things, excessive physical stress we should avoid, malnourished nutrition we should avoid. So specific sounds like Venu Ghasha means sound which generates due to wind through bamboo shoot. So this is the Samprapti, what we cannot, is a pathogenesis in Ayurveda, Sushruta Tantra chapter number 20-21. In Uttar Tantra, this is the Vata Prakopa is responsible, vitiated Vata dosha is responsible, and whole theory of Karnanada सराउंड्स, ये कर्णनादा सब एक ही थियरी के ऊपर चक्कर लगाते हैं और वो है वात प्रकोप. और वात प्रकोप को हम कैसे अरेस्ट करते हैं, और उसके लिए आकाश महाभूत, हमारे ऑडिटरी कैनाल में है आकाश महाभूत, और हमारा जो कॉक्लिया, सेमी सर्कुलर कैनाल, वेस्टिबुल, ऑल थिंग्स इफ यू सी केयरफुली, दिस इज अ लॉट ऑफ स्पेस विच इज फिल्ड विद एंडोलिम्फ, लैब्रिंथाइन फ्लूइड, व्हाटएवर, इवन ऑडिटरी कैनाल, उसमें आकाश महाभूत है. यू नीड टू कॉन्सेंट्रेट ऑन आकाश महाभूत, यू नीड टू कॉन्सेंट्रेट ऑन वात प्रकोपा एंड द कॉजेस और अफेक्टिंग फैक्टर्स, पॉजिटिव फैक्टर्स विच अफेक्ट्स द ईयर बाय क्रिएटिंग रिंगिंग साउंड एंड कर्णश्वेता, टिनिटस. सो कर्णनादा ये जो बताया है, कर्ण कंडू, रात्रि जागरण, अगेन मिथ्या योगा. देखो आजकल ईयरबड डालने की फैशन हो गई है. I don't know who has invented this earbud. ENT surgeon never advises patient buy the medicine, buy these earbuds from the shop and they start cleaning of their ear and that kind of thing. Silly things ये patient करते हैं, और they in that process they create a trauma and they hurt the tympanic membrane. So मिथ्या योग. फिर कोई लोग तो गाड़ी की चाबी कान में डालते हैं. They try to put key in their auditory canal. बोलते there is a patient can't hold the itching, automycosis जब आता है, that kind of things, external instrument वो कान में डालते रहते. Then there is a recurrent repeated history of pratishay. All of you know how pratishay is the culprit because नासा ही शीर्षोद्वारम और वहां से ही स्टेशन ट्यूब थ्रू आपका मिडल ईयर गेट्स अफेक्टेड एंड ऑल द ड्रेनेज पोर्ट थ्रू स्टेशन ट्यूब टू द योर ऑडिटरी कैनल. और उसमें अगर प्रतिशय भी क्यों होता है, अगर मैं कहूंगी स्पेसिफिक हेतुज आपको देखना है टिनिटस के, तो आपको प्रतिशय से भी स्टार्ट करना पड़ेगा. नासा शीर्षोद्वारम. व्हेन योर रस धातु इज नॉट गुड, व्हेन देयर इज अ दुष्टि ऑफ रसवह स्रोतस. रसवह स्रोतस की दुष्टि जो होती है, हमको भूताग्नि पे कॉन्सेंट्रेट करना पड़ेगा, हमको जठराग्नि पे कॉन्सेंट्रेट करना पड़ेगा, हमको हर एक धातु का धात्वाग्नि बंध का कॉन्सेंट्रेट करना पड़ेगा. हम क्या खाना खाते हैं, हम कितने बजे सोते हैं, हम कितने बजे उठते हैं, व्हाट काइंड ऑफ लाइफस्टाइल वी आर हैविंग. अ थरो एंड डिटेल हिस्ट्री टेकिंग इज मोस्ट इंपॉर्टेंट एज पर द आयुर्वेदा कंसल्टेशन इज कंसर्न्ड ऑफ नॉट ओनली टिनिट्स but any disease. तो specific hetus is lack of proper diet, धातु क्षय. What will happen? अगर हम वात प्रकोपक डाइट लेंगे, it will lead to धातु क्षय, isn't it? Lack of proper diet will cause to धातु क्षय, which ultimately causes वात प्रकोपा. अगर धातु क्षय मैंने बताया, रक्त धातु का क्षय हो गया, रस धातु का क्षय हो गया, मज्जा क्षय हो गया, it will definitely aggravate your वात प्रकोपा. और vice versa, if your vata dosha is vitiated or prakopit, then it will definitely hamper your dhatus. When there is a dosha prakopa or dosha aggravation hota hai, then aggravated vata dosha will definitely hamper your all dhatus, and thereby when there खवैगुण्य occurs. आप कहेंगे वात प्रकोप हो गया तो टिनिटस से क्यों होगा? वात प्रकोप होगा तो देयर आर एन नंबर, उसको हेमीप्लेजिया हो सकता है, पैरालिसिस, उसको लंबैगो पेन हो सकता है. देयर आर एन नंबर ऑफ थिंग्स की वात दोष प्रकोप से 80 प्रकार के वात व्याधि बताइए. लेकिन when all of you know the theory of Kha-Vaigunya, unless and until there is a Kha-Vaigunya, definitely Kha-Vaigunya is there, then only aggravated and vitiated vata is all over body circulating. It will combine with the dhatu and then favorable condition comes. All of you know Chaya, Prakop, Prasar, Sthana, Sanshra, Vyakti and Bhed. So to cover this topic particular, tinnitus ayurveda management, you will have to go to the ऋतुचर्या. अष्टांग संग्रह में फर्स्ट ईयर में जब बच्चा आते हैं तो सबसे पहले उसको दिनचर्या बताते. इफ योर दिनचर्या इज नॉट गुड, यू आर नॉट फॉलोइंग आयुर्वेदा. इफ योर ऋतुचर्या इज नॉट गुड, आप 10 बजे 11 बजे खाना खाते हैं, 1 बजे सोते हैं, मॉर्निंग में 10 बजे उठते, 9 बजे उठते हैं, दैट काइंड ऑफ थिंग्स एंड कंप्लीट डिटोरिएशन अगर आपको करना है तो अंजन करने के लिए बोला है, प्रतिमर्श करने के लिए बोला है, नस्य करने के लिए बोला है. सो दिस वाता प्रकोपा एंड देन वाता गोज टू शब्दवह स्रोतस. दिस इज शब्दवह स्रोतस, इट कॉजेस कर्णनादा. हम शब्दवह स्रोतस को क्या कहेंगे? शब्दवह स्रोतस को हम कर्णेंद्रिय जिसको कहेंगे, सेंस ऑर्गन इंपॉर्टेंट. दिस इज कॉक्लियर नर्व, इंटरनल ईयर पार्ट, कॉक्लियर नर्व, वेस्टिबुलर नर्व और सेंटर ऑफ हियरिंग, ये हमारा शब्दवह स्रोतस है. हमारा ऑडिटरी कैनल कोई शब्दवह स्रोतस नहीं है. ऑडिटरी कैनल रहेगा तो भी पेशेंट को सुनाई देता ही, ऐसा नहीं. The patient hears sound like bheri and mridanga. So etiology again, this is the stress and over pollution, over crowding. आपको पता है कि हम right now we are living in the era of stress, रेस्टलेस शेड्यूल. अभी 12 घंटे इंसान लैपटॉप पे काम करेगा, कान में वो ईयरफोन डाल के बैठेगा. व्हाट विल हैपन टू देयर ईयर्स एंड आईज? What will happen to their sense organs? What will happen to their cornea? It will leave your cornea dry. It will hamper your cochlear nerve. It will hamper your श्रोत्रेंद्रिय. So if your ears are exposed in sound and air pollution, आप मुंबई जैसे सिटी में हो, आप अपने व्हीकल से निकले हो कार में बैठ के, और आप दिल्ली जैसे सिटी हो, there's a lot of noise pollution, air pollution in that. Because of that hazardous, that will cause an hazardous effect on your sense organs. So mechanical trauma, chemical impulse, electrical impulse, there are n number of electrical impulse. Just now अतुल भारद्वाज सर ने बताया कि नेजल ड्रग डिलीवरी सिस्टम एंड क्रिबिफॉर्म प्लेट के थ्रू जो जाता है एक्वस फॉर्म और लैपोडियल फॉर्म, द सेम वे impulses नहीं है कि आपको इवन इलेक्ट्रिक वो इम्पल्स आपका जाता है, दैट इम्पल्स विल इंड्यूस, इट विल एक्ट ऑन योर हाइपोथैलेमस पे आपकी एक्शन होती है, और वो हाइपोथैलेमस विल कॉजेस द एंडोक्राइन हार्मनी, जिसको हम श्रृंगार काइंड ऑफ द स्टॉक ऑफ द पिट्यूटरी के ऊपर हमारी नस्से की ड्रग डिलीवरी होती है। और नस्से इज ऑल्सो लाइन ऑफ ट्रीटमेंट फॉर टिनिटस, नॉट ओनली कर्णपुरन, नस्से इज ऑल्सो लाइन ऑफ ट्रीटमेंट फॉर टिनिटस। सो क्लिनिकल फीचर्स कर्णनादा इज मैंने बताया एक सिंगल सिम्टम भी रह सकता है और दैट कुड बी अनदर सिम्टम्स बिकॉज ऑफ द पर्टिकुलर डिसीज। अगर आयुर्वेद ने क्या बताया कि डेफिनेट कोई पूर्व रूपा ऑफ मेनी रोगस, मतलब अपस्मार है, अभी इपिलेप्सी का अटैक आना है पेशेंट को, इफ पेशेंट इज फीलिंग माइग्रेन, अटैक ऑफ इपिलेप्सी और उन्माद, अपस्मारा, ग्रहिणी, दैट काइंड ऑफ पर्टिकुलर दिस इज पेशेंट में फील अ पूर्वारोपा लाइक टिनिटस। इवन माइग्रेन में भी कुछ पेशेंट कंप्लेंट करते हैं कि हमको बहुत आवाज सुनाई दे रही है और उसके बाद हमें चक्कर आता है। दिस रूपा, व्हाट आर द क्लिनिकल फीचर्स? क्लिनिकल फीचर्स में क्या बताया? डिफरेंट टाइप्स ऑफ साउंड हर्ट हियरिंग इन शब्दवह स्रोतस। शब्दवह स्रोतस है, चाहे आपको कार्टिलेजस पार्ट हो, आपका बोनी पार्ट हो, इफ यू सी द कंस्टिट्यूशन और कंपोजिशन ऑफ श्रोत्रेंद्रिय और ईयर, देन यू विल कम टू नो दैट अस्थि धातु का, उसमें अस्थि महाभूत का, उसमें वाता, जैसे मैंने बताया बहुत सारे स्पेसेस है, ऑडिटरी कैनाल से लेकर उनका वेस्टिबुल सेमी सर्कुलर कैनाल में, दैट इज फिल्ड योर वाता दोषा। इसलिए आपको टिनिटस अगर करना है तो आपको कंपोजिशन, पंच महाभूतिक, ऑर्गेनोलेप्टिक इवैल्यूएशन, व्हाट यू ईट, दैट इज आल्सो पंच, and the medicines you are using, that are also panchabhautik medicines. Even ना उसका कंपोजिशन क्या होगा, तिक्त रसात्मक औषध अगर है तो आकाश महाभूत के ऊपर काम करेगी। दैट काइंड ऑफ वे हम लोगों को बहुत ज्यादा अच्छे से उसको एलेबोरेट करना पड़ेगा। सो विधि विविध शब्द लाइक भेरी, ये पता है कि आचार्य हरित ने भी इसको एक्सप्लेन किया है। अभी आप रूप बोलेंगे तो रूप उसका एक ही है। रूप एक है कि आपको आवाज सुनाई देते हैं, और क्रिपिटस ऑफ टीथ, फ्लूट विद बर्निंग, अगर बांसुरी आवाज सुनाई देना, रिंगिंग बस, एंड उसके बाद क्रिपिटस ऑफ टीथ, ये दिस काइंड ऑफ ओनली 2 to 3 सिम्टम्स, पर्टिकुलर साउंड डिस्क्राइब किए, अलग अलग फॉर्म ऑफ साउंड। सो की रोल प्रिवेंटिव मेजर, जस्ट नाउ इन द प्रीवियस स्लाइड आई टोल्ड यू what is identifying a nidana. Suppose a patient comes to my OPD and he is complaining of tinnitus, I would first take a detailed history and identify what could be the cause. And if a patient goes, I am working in the factory, I will advise him to put an earplug, and I would advise him to Purana Pratimarsham was daily till this kind of thing. So how can just when digitalized syndrome, जब आंखें ड्राई हो जाती है तो हम बताते हैं हर 20 मिनट के बाद आपकी आंखें बाजू करो, ब्लिंक करो, you should blink often so that your corneal tear film won't get evaporate. So आप 7 to 8 inches नीचे रखो. That kind of practices we will have to implement preventive measures. Preventive measures हमें करना है. Then संप्राप्ति, just now I told you, तो और विशिएटेड वात दोषा when encircled with कफ दोषा. कुछ आचार्यों ने बताया है कि केवल वात दोषा इज रिस्पॉन्सिबल, कुछ आचार्यों ने बताया इट इज encircled by कफ दोषा in the शब्द वह स्रोतसा and produces different types of sound. So then vitiated vata dosa lodged in the शब्द वह स्रोतसा and it induces the. अभी हम लोगों को if we know the संप्राप्ति, अगर आपको हेतु का पता चले, then you can reversion. All of you know, first thing we should prevent, we should ask the patient to have a healthy practices कि ईयर कैसे हेल्दी रह सके. Second thing, we should concentrate on pathogenesis, means we should break the chain, we should we should counsel the patient कि you should not expose your ears more than 80 decibels, you should not hear sound more than 80 decibels. If the patient is on anti-diabetic medicine, you should try to minimize the doses of metformin and sorbitrate. Ayurveda is having a very wonderful theory as far as diabetes is concerned. You can advise the patient walk 4 to 5 kilometers, ask them to go for pranayama, try to lower down the blood sugar. जैसे ही 38-40 साल का पेशेंट आता है, डॉक्टर ब्लड शुगर हाई आती है, मॉडर्न साइंस उसको इमीडिएटली डालते हैं कि आपको ये मेटफॉर्मिन लेना पड़ेगा. इवन 1 महीना भी पेशेंट को नहीं देते हैं कि पेशेंट उसको कुछ तो भी सेल्फ ये कर सके कि वो पेशेंट हिमसेल्फ कैन लोअर डाउन, इफ पेशेंट कैन रिड्यूस 5 kg weight. I am talking about type 2 diabetes. If the diabetes is culprit, and if it is a type 2 diabetes, we should, Ayurveda consultant should take charge of that diabetes. First treat the diabetes, your tinnitus will get controlled. So vata dominance, tridosha, grita having property of sanskara, avartana, when processed with Vatashamaka drug, the ashwagandha, bilva, and that kind of medicines I told you, the use of sneha, especially tela, helps to subside vata dosha and clear the channels. So ashwagandha, there are n number of herbs. In a 1.5 hour lecture, it is not possible for me to elaborate all Ayurveda line of management, but I am trying to emphasize on ashwagandha, Vidania somnifera, and we should have a faith. It is mentioned, बहुत सारे लोगों को बहुत कुछ पता रहता है, लेकिन जब ट्रीटमेंट हम करते हैं तो हम मेडिसिन के ऊपर विश्वास नहीं रखते, बिकॉज इट इज अ वेरी सिंपल वे, वेरी सिंपल थिंग्स. हमें कॉम्प्लिकेटेड अगर कुछ बताया जाए तो हम हमारा फेथ हो जाता है. जैसे इंजेक्शन रेमडेसिविर, अगर जलनीति बताएंगे या कोई पर्टिकुलर मेडिसिन बताएंगे तो हम नहीं ध्यान देते. सो तो अश्वगंधा, विदानिया सोमनिफेरा हैज रसायना, बल्य, ब्रिहणा प्रॉपर्टीज. All of we know how it can prevent age-related degeneration. It will arrest the dhatusha. It will improve the neurons और जो neurological health है आपके tissues की, वो माइटोकॉन्ड्रियन पे सेलुलर चेंजेस है उसमें काम करती है अश्वगंधा. इट इज यूज एन एडाप्टोजेन सब्सटेंस सेट टू इंक्रीज द एबिलिटी टू विथस्टैंड द स्ट्रेस. इट विल डेफिनेटली एंटी एंजाइटी, एंटी डिप्रेसेंट, रसायना, चक्षु, दैट काइंड ऑफ एन नंबर ऑफ थिंग्स अश्वगंधा is doing. It is an adaptogen. Like other adaptogen, ashwagandha is supposed to improve the strength of the particular organ also. Cochlea and hearing capacity. Definitely, अगर आप अश्वगंधा का सेवन करते हो और आप प्रॉपर डोजेस में कर रहे हो, प्रोवाइडेड योर अग्नि. देखो, विदानिया सोमनिफेरा वर्स मीन, अगर आप कल पेशेंट को विदानिया सोमनिफेरा दोगे 1-1 चम्मच, तो पेशेंट का टिनिटस कम नहीं होगा. आपको उसका जठराग्नि, उसका धातु अग्नि मानदेत्व, उसका चय प्रकोप प्रसर, वे सबके काम करना पड़ेगा. अगर जैसे अभी अतुल सर ने बताया कि देयर इज आमम एंड यू आर पुटिंग अणुतेलन, इट वोंट सॉल्व द पर्पस. फर्स्ट टेक द डिटेल हिस्ट्री वेयर देयर इज आम संचिति, where is the pakvavastha, jirnavastha, ama sanchiti, then you should try take efforts to reduce the ama sanchiti agar hai to wo kam karna hai. Thereafter you can give ashwagandha. So all these properties help in improving the blood supply to the inner ear and reduce the acuity of the tinnitus felt by the patient. I am talking about subjective tinnitus felt by the patient. So ashwagandha helps to produce serotonin. So this is a very important chemical for serotonin. When a serotonin releases in the body, it is a very feel-good hormone. It is a hormone which is released by level. Check karo before after ashwagandha आप रखो and check the serotonin level. If it sits in your body, what will happen? Patient will feel good. अचानक उसको लगेगा मुझे बहुत अच्छा लग रहा है. Patient is very happy. उसका mood elevator कराता है ये serotonin. So oral administration of ashwagandha ghruta acts on the central nervous system. It acts through its GABAergic modulation. So as well as it is a role to increase the acetylcholine receptor activity, stimulating the growth of axons and dendrites. जैसे मैंने बताया, नर्व सेल्स के जो एक्सॉन्स होते हैं और डेंड्राइट्स होते हैं, इसकी हेल्थ अश्वगंधा इंप्रूव करता है. देयर आर एन नंबर ऑफ ड्रग्स लाइक अश्वगंधा. दशमूल तैला एंड अश्वगंधा घृता बोथ हैव वाता, शामक एंड रसायना प्रॉपर्टीज. सो आयुर्वेदा बिलीव्स इन पर्सनलाइज्ड थेरेपी. ऐसा नहीं है कि आपके पास 4 टिनिटस के पेशेंट आएंगे कि चारों को आप अश्वगंधा घृत दोगे और दशमूल तेल दोगे and it will solve the purpose. No, you will have to go for prakriti parakshana. That is called personalized treatment. It is not a universal treatment. Ayurveda don't believe in universal treatment. Ayurveda believe in prakriti parakshana, personalized treatment, and then we can plan a particular medicine for particular patient. So correlation with the other clinical condition. If one hears sound of thundering, it's due to kapha dosha. It is also has been explained as a लक्षण of this slide repeat हो गई है. So आयुर्वेदा मैनेजमेंट में महामाश तेल है, अश्वगंधा तेल है, दशमूल तेल है, मधुकारी तेल है, सरसप तेल है, and number of things.
Hello, madam, you are not audible. बघा मॅडम, आपलं काय हे झालं का लिंक बघ बरं.
Hello.
हाँ बोले क्या?
I'm audible, sir?
हाँ, now you are audible.
And what about my slide?
Slide share not available.
Because I got disconnected in between, that's why I'm asking you. Slide
Slides
share,
not visible, ma'am.
slides दिख रहे?
Share your slide.
Ayurveda management Mahamash Tela.
Not visible.
Visible?
Not visible. Gujarat. Madam, your slides are not visible. हॅलो मगर मॅडम, माझा आवाज येतो तुझ्या? गुड मॉर्निंग सर. डॉक्टर आर यू देयर? Solve this technique. Okay.
हॅलो.
हॅलो.
हा मोरे सर, मी आवाज येतोय?
हा,
माझा आवाज येतोय ना?
हो हो,
हॅलो.
तुमचा आवाज येतो सर.
मॅडमला म्हणा एकदा लेफ्ट व्हा आणि परत. हॅलो. हा
लेफ्ट
मॅडम,
होऊन परत join
मगर
व्हा.
मॅडम. हा हा. आणि मग त्यांना को होस्ट करा. हॅलो.
हा ओके. मगर मॅडम, हॅलो.
त्या बहुतेक लेफ्ट झाल्यात.
तर मी कॉल करतो त्यांना.
हा, त्यांना जॉईन व्हायला सांगा. त्या लेफ्ट झाल्यात.
होत आहेत मॅडम, जॉईन होत आहेत.
त्यांना परत को होस्ट करा.
परत पोस्ट पूजा.
मॅडम जॉईन नाही झाल्या अजून. हा, जॉईन झाल्यात मॅडम.
मगर मॅडम,
हा, जस्ट जॉईन झालेत मॅडम आता.
yes. You can start your lecture, madam. Continue, please. केले ना पोस्ट.
हॅलो.
परत नाही म्हणून त्यांना पोस्ट
हा
केला आपण.
मगर मॅडम. हो हो. त्यांना ऐकू येत नाही वाटतं ऑडिओ. Hello, they joined me proper.
मगर मॅडम इज नॉट जॉईन आहे त्या.
हा जॉईन झाले पण ते बहुतेक दुसऱ्या मोबाईलवरून जॉईन झाले त्याच्यात. हॅलो. हा मगर मॅडम हॅलो.
अरे यार पाऊस येतो तुझ्या लवकर जात होतं घरी. हम्म. हम्म.
मोरे सर हॅलो.
हा
हॅलो.
सर बोला.
हा मॅडमला को होस्ट करा ना.
पूजा पूजा केलं. यस मगर इज नाव पोस्ट. ओके. हाँ यस मैडम यू आर विजिबल मैडम.
हा येस. हॅलो. हा मगर मॅडम. हॅलो. हॅलो मगर मॅडम कॅन यू हेअर मी.
मैडम इज विजिबल.
हॅलो. हा मॅडम तर
पूजा
मॅडमला आवाज जात नाही.
अनम्यूट केलेलं आहे मॅडम.
मॅडमला आवाज जात नाही होती.
Yes, you can see the screen now.
Screen is
See.
not visible. You are audible but the screen is not visible. बारिश हो रहा है जल्दी में. Madam not visible and not audible. What happened? मग सर काय करायचं.
हॅलो मॅडमचं काय प्रॉब्लेम येतोय? हॅलो
मगर मॅडम मगर मॅडम अरे हे झालं 2 मिनिटात ते पैसे 2 मिनिट 2 मिनिटात 5 मिनिटात हो ना हे तर मध्ये मध्ये प्रॉब्लेम त्यांचं ते होत आहे का? काय करावं आता? झालं का? मोबाईल वरून पाऊस यायला लवकर जा पाहिजे. हॅलो
दोन लेक्चर होते ना.
झाला का जॉईन मॅडम?
पुन्हा का? अरे यार
हा झालेत मॅडम. हा ओके ओके. हा हॅलो मॅडम. हॅलो हॅलो मॅडम. हॅलो मे ऑडिबल. ओके ठीक. कोण आहे आता? दीपक आहे ना? हॅलो हॅलो. हॅलो हॅलो मे ऑडिबल डॉक्टर दीपक सावंत. हॅलो हॅलो दीपक सावंत. दीपक सावंतला को होस्ट कर. डॉक्टर दीपक सावंत को होस्ट कर.
हेलो हेलो.
हॅलो हा दीपक.
हाँ हेलो सर.
हा हा. Due to some technical issue, we are not able to connect with Dr. Sunita Magar, madam. I would request you
Okay.
to conclude this session.
Okay sir. Am I audible sir?
Yes, yes.
Sir, I am audible. Yes. Okay sir.
Yes, you are
Good
audible.
afternoon everybody. Yes. Okay. Thank you sir. I first of all thankful to APM'S AYURVED College, SION College, Principal Satpute sir, Dr. Ravi More sir, HOD, and Dr. Arun Dudmal sir. Give me opportunity to just moderate the session in webinar. In second session, Dr. Magar madam giving a very innovative and classical lecture on the tinnitus. That is theoretically very simple condition, but it is therapeutically or management point of view very much agoning or very much tedious to treat the condition. But Magar madam
बंद करून
explain
देशील.
the text and classical
Vote of thanks.
classically,
यांचं झालं की vote of thanks
theoretically
म्हणायचं.
and mostly modern science and Ayurvedic science in brief and in details and minutely she explained the all the types,
केलं
etiological
बंद केलं
factors.
त्यांचं. दीपकला सांगितलं
Okay.
मला.
She she just explained all the modern science, the etiological factors, clinical features, types, and the classification of tinnitus and the management of tinnitus as per point of modern science. But Madam explained the all tinnitus or Karnaksved Ayurvedically very nicely. The management point of view, the Vataprakop Janya and Margavrod Janya tinnitus or Karnaksved is mostly managed.
ठीक है, बोलून लगेच बंद करू नका. हा.
With the help of the Snehan, Svedan, Chikitsa is very important because the team, organizing committee, and thank you all. Thank you, sir. Hello, sir. Thank you, sir.
Very much.
Hello.
Hello. Ah, thank you very much,
Thank you.
sir. Okay. Now I request to hand over to doctor. Please, you don't vote of thanks.
Yes, sir.
Oh, hello. Hello.
Hello, sir.
हाँ. Due to some technical issue, we are winding this session. But I want to mention vote of thanks to Dr. Bhardwaj sir of Brahma Prakash Ayurved College, New Delhi. Dr. Sunita Magar madam from YMT Ayurved College, Kharghar. Deepak Sawant sir, Ayurved, Usmanabad. And hello, Dr. Sarla Dudat madam from Podar Ayurved College, Navi Mumbai. Also, I thanks to all participants and extremely sorry due to some technical issue and heavy rainfall. We are winding this session as a technical issue is there. Therefore, we are winding this session. Thank you very all participants, speakers, and moderators. Thank you very much.
Thank you, sir. Thank you. Thank you very much, sir.
Okay. Thank you, sir. Thank you.
Thanks all, sir. Thank you.
Oh.